Hi everybody, and welcome to our module on the lens. If you look at your eye in the mirror, you will see something like what's shown on the left side of the screen here, and the dark circle in the middle of your eye is called the pupil, and I talk about the pupil in a separate module. The pupil is a space that allows light to enter the eye and hit the retina in the back of the eye, and the retina is what creates an image of the world around us. What you can't see, however, when you look in the mirror is that on top of the pupil is a clear structure called the cornea, and behind the pupil is another transparent structure called the lens. And the cornea and the lens work together to focus light into the back of the retina so that you can create an image of the world around you. The cornea and the lens are transparent structures that focus light into a focal point. This is a process known in physics as refraction. Large objects give off lots of light, and a lens can focus that light into a focal point. In the eye, most of the refraction is performed by our cornea. It focuses light into a focal point that ideally falls on the retina. The amount of refraction that the cornea performs is fixed and cannot be adjusted, however. A smaller amount of refraction is performed by the lens, and this is important because the lens is adjustable and can modify the amount of bending of light so that we can focus on objects close to our eyes. The lens of the eye has some very unique properties that allow it to change shape and modify the amount of refraction that the lens performs so that you can focus your eye on objects. The lens is surrounded by a capsule that contains type 4 collagen. It is an avascular structure. Nutrients are obtained via diffusion. The inside of the lens contains elongated fiber cells, and these cells perform mostly anaerobic metabolism. The principal source of their energy is the metabolism of glucose into lactic acid. Accommodation is the process by which the lens modifies its shape to focus on near objects. When the lens does this, it changes the optical power of the eye. If you look at this drawing of the front half of the eyeball at the bottom of the screen, you will see that the lens sits behind the pupil and that it is connected to a structure called the ciliary body. Within the ciliary body, you can find the ciliary muscle, which is a smooth muscle that can change the shape of the lens. It's a circular muscle that surrounds the lens, and it's connected to the lens by ligaments, which are known as zonules, and they're shown here in white in this picture. In the resting state, when you are not trying to focus on a near object, the ciliary muscles are relaxed. This pulls the zonules tight and flattens the lens, as I've shown in this picture on the screen. And this is what your lens is doing when you focus on faraway objects. When you try to look at a near object, this is the process of accommodation. The ciliary muscles contract. This actually makes the zonules relax and the lens rounds, and this allows you to focus on objects closer to your face. And just to make this even more clear, here's another picture. When we're looking at faraway objects, the ciliary muscles are relaxed and the lens is flatter, as I've shown in this picture at the top of the screen. When we focus on something near to our face, the ciliary muscles contract, the lens becomes rounder, and this slightly modifies the optical power of the eye to let us focus on things that are close to our face. Many of your elderly patients will require reading glasses like this man shown in the picture here. The reason for this is because of a pathologic process called presbyopia. As we age, the lens stiffens and thus it cannot focus on near objects for activities like reading. As a result, we're not able to accommodate normally, and many patients as they get older require reading glasses. Part of the physical exam for the eyes is to test what is known as the accommodation reflex. These are 3 reflex responses that occur as an object is moved closer to the eye of a patient. So in order to test the accommodation reflex, you ask a patient to focus on your fingers, and then you move your fingers closer to their face. 3 things will happen as a reflex response to the fingers moving closer to the face. First of all, the eyes will converge. They will both move medially to track the object. Secondly, the pupils will constrict. This is called miosis, and this is done to prevent the entry of divergent light rays from the near object. And then finally, the lens will accommodate. You can't see this on physical exam, but this is the 3rd component of the body's accommodation reflex. The shape of the lens changes and the focal point is thus maintained on the retina. So when you test the accommodation reflex and you say that it is normal, you mean that you ask the patient to follow your finger towards their nose and their eyes converged and their pupils constricted. Now I'm going to talk about refractive errors. These are vision problems that result from an abnormal focal point of the eye. In other words, a focal point that does not fall properly on the retina. These types of vision problems are treated with glasses or contact lenses, and most of the people you know who wear glasses or contact lenses do so because they have a refractive vision error. To understand refractive errors, you need to appreciate that the corneal curvature of the eye has to match the size of the eye. Remember that the cornea does most of the refraction of the eye, and it needs to bend light to a focal point that ideally settles right on the retina. Sometimes as we grow, this process doesn't work out just right. Neither the cornea has too much or too little curvature, or the eye is too big or too small, and as a result, the focal point is not on the retina. So in other words, if the curvature of the cornea doesn't match the size of the eye, this leads to a refractive error. The first refractive error that we'll discuss is myopia, which is also called nearsightedness. This occurs when the focal point is in front of the retina. I've shown this in a drawing on the screen. The cornea is focusing light at this point here, which is not the retina, it's in front of the retina. This happens when the eye is either too long or the cornea has too much curvature so that the focal point ends up not on the retina. And when this happens, patients cannot focus on far away objects, thus they are called nearsightedness. Nearsightedness and farsightedness are named for the field of vision that is normal, so in these patients near-sighted objects are okay, but far-sighted objects are blurry. Here's another picture from the web just to make this more clear. In myopia or nearsightedness, you have a cornea that's generating a focal point that is not on the retina. This will happen if there's too much curvature to the cornea or if the eye is too big. Myopia can be corrected with lenses, and in this case you need a negative lens to correct the vision problem. A negative lens spreads the light out more, and thus when the cornea does its focusing, it will direct the focal point now onto the retina instead of in front of the retina. So for example, my glasses have a prescription of negative 1.75, and that's to correct myopia. And this is another picture from the web just to make this even more clear. In the myopic eye on the top, the focal point is in front of the retina. The negative lens spreads the beam of light out a little bit more before it reaches the cornea. This corrects the focal point so that it falls on the retina. Hyperopia is the opposite problem. This is farsightedness. In this case, the focal point is behind the retina, as I've shown on the screen here. This happens when the eye is either too short or the cornea has too little curvature. This results in eyes that cannot focus on near objects, and thus the patient is called farsighted. And once again, here's another picture to make this more clear. You have an eye that is either too short or there is not enough curvature to the cornea, thus the focal point ends up behind the retina. Hyperopia is connected with a positive lens. This is basically a magnifying glass. It focuses the light a little bit more before it reaches the cornea, and thus when the cornea focuses the light, it ends up falling on the retina. And an example of a positive lens is a lens prescription of plus 1.5 or plus 2.0. These are positive lenses to correct hyperopia. And here's another picture from the web just to make this very clear. In an eye with hyperopia, you have either not enough curvature or too short of an eye, and thus the focal point ends up behind the retina. A positive lens will focus the light slightly before it reaches the cornea, and this will correct the problem and put the focal point on the retina. The final refractive error that we'll discuss in this video is called astigmatism. This occurs when there is an uneven curvature of the cornea. Thus the cornea generates multiple focal points and objects become blurry. A normal cornea is circular, like what I've shown on the left side of the screen. In astigmatism, the cornea is shaped more like a football. This means that light will be focused differently in this plane compared to this plane, and thus multiple focal points can occur and the image can appear blurry. And just like myopia and hyperopia, astigmatism can be corrected with lenses or sometimes with surgery. Moving on from refractive errors, let's talk about ectopia lentis, which is dislocation of the lens. This most commonly occurs due to trauma. People who get in fights and get punched in the eye can have dislocation of the lens. But what you should know for step 1 of your boards is that rarely this condition is associated with a systemic disease, and it can occur as an ocular manifestation of some systemic disorder. Here's a picture of what ectopia lentis can look like. You can see when you examine the pupil that the lens is off-center behind the iris. The two systemic disorders that are associated with ectopia lentis are the Marfan syndrome and homocystinuria. Marfan syndrome is the most commonly associated systemic condition. It is an autosomal dominant disorder that leads to a fibrillin defect. Patients with the Marfan syndrome have a very typical phenotype. They're usually very tall with a long wingspan. In addition, 50 to 80% of them will have dislocation of the lens, and classically, the lens is dislocated upward and outward. In homocystinuria, children are born with a deficiency of the enzyme cystathione beta synthase. I talk about this enzyme deficiency in detail in the biochemistry section. Children with homocystinuria have markedly elevated homocysteine levels. They also have a Marfanoid body habitus, meaning that they are usually tall with a long wingspan, just like patients with the Marfan syndrome. They often have mental retardation, and classically the lens dislocation in homocystinuria is downward and inward. Cataracts of the lens are a very common eye disorder and something that you will definitely see clinically. A cataract is an opacification of the lens. This is an example on the left of a patient with a cataract. And when the lens becomes opacified, that disrupts the passage of light through the lens and into the retina, and that leads to cloudy vision. So the definition of a cataract is an opacification of the lens. It's a painless process. It leads to decreased vision, and it's treated with cataract surgery. And if you become an ophthalmologist, one of the most common surgeries you will perform is to remove cataracts. One of the major risk factors for development of cataracts is older age. Most of us, as we age, will develop cataracts, and most of the patients who require cataract surgery are elderly. Smoking and alcohol are associated with cataracts. This association has been determined via case-controlled studies. The mechanism is not well understood. Excessive sunlight can lead to opacification of the lens. Patients who take long-term corticosteroids, like patients with rheumatoid arthritis or sarcoidosis, develop cataracts at increased frequency compared to patients who do not take steroids. And then finally, if you've had any eye problem like trauma or infection, you're at increased risk for the development of cataracts. Two other disorders that are risk factors for cataracts are diabetes and galactose metabolism disorders, and the biochemistry of these disorders is high yield, so I'll review that now. There's an enzyme found in the lens of the eye called aldose reductase. This is part of a metabolic pathway called the polyol pathway. This enzyme can convert glucose into sorbitol. It can also convert galactose into galactitol. Now, normally, this enzyme has very low levels of activity. However, if you have diabetes and you have lots of glucose around, or if you have a galactose disorder and you have lots of galactose around, then this enzyme can create high levels of sorbitol or galactitol in the lens of the eye. That will draw in fluid and lead to an increase in the lens osmolarity, and this is a way that you get cataracts in either diabetes or a galactose metabolic condition. So diabetes is a well-established risk factor for development of cataracts, and the mechanism is believed to involve the metabolism of glucose into sorbitol in the lens by the enzyme aldose reductase. The sorbitol can be broken down into fructose, but this is a slow process, and thus the level of sorbitol in the lens can get very high. This will draw in fluid and lead to an opacification of the lens. I talk about metabolic disorders of galactose in the biochemistry section, but I'll just review here that there are two inborn errors of metabolism that lead to very high galactose levels, and these conditions can lead to the development of cataracts in children, which is very unusual. Classic galactosemia presents in infancy with liver failure and development of cataracts. Galactokinase deficiency is a milder form of galactosemia. The main problem in children who have this disorder is that they will develop cataracts as a child or young adult. And the mechanism of cataracts in both of these disorders is believed to be that aldose reductase converts galactose into galactitol in the lens, and that leads to a high osmolarity which draws in fluid and opacifies the lens. Finally, I'll finish with this slide and mention the torch infections. These are the infections which are dangerous to the fetus if they occur during pregnancy. A number of these can potentially lead to cataracts in babies. Classically, cataracts are part of the congenital rubella syndrome. If a mother develops rubella, her child can be born with the rubella syndrome, which includes cataracts. In addition, these children are typically deaf, they often have cardiac malformations, and they classically have blueberry muffin skin, which is skin that is blue because hematopoiesis is occurring in the skin. This is extramedullary hematopoiesis, and it occurs as part of the congenital rubella syndrome along with congenital cataracts. And that concludes our module on the